So good morning. I am Dr. Mohammed Matar, interventional cardiologist from Iraq. It's my great pleasure to chair this session together with my colleague, Dr. Raad Aqil. He's interventional cardiologist from Jordan. I would like to present the lovely panelists, Dr. Amr Al-Karmi from Jordan, Marwan Al-Namri from Jordan, Dr. Walid from Jordan, Rashid again from Jordan, and Yahya Ismail from Palestine. So in this session we have three speakers. So in this session we have three speakers. Every speaker have 10 minutes for his presentation, and thereafter the discussion will be open. Now we are going to move for Dr. Hani Abdelhadi from Saudi Arabia. He will talk about the role of the intravascular imaging in the contemporary bifurcational PCI.
Shall I go ahead? Yalla. Okay, so it's a pleasure to be here today. So coronary bifurcations account for up to 20% of interventional procedures, and they tend to have worse outcomes than non-bifurcation PCI. Yes? Okay, ready? Yalla, second time lucky. So coronary bifurcations account for about 20% of PCI procedures, and we know that these have worse outcomes compared to non-bifurcation PCIs, higher MACE rate, higher rate of stent failure, particularly in the long term. Where did my presentation go, ya shabab? And there are specific, well, there's no images initially, so there are specific challenges in bifurcation PCI. We've got difficulties with sizing, particularly over the carina, but you've got main branch, side branch, and carina that you need to size. Difficulties in assessing the side branch ostium. And if you have a suboptimal result in either your main branch or your side branch, you can compromise both branches in the long term. Intravascular imaging gives you superior anatomical and morphological information, which helps guide your PCI strategy and helps guide your device selection. And you also get a more optimal PCI result. So you ensure that you have better lesion preparation, you achieve optimal expansion and apposition, you're more likely to avoid dissections if you sized your vessels properly, and you're more likely to identify your dissections with imaging and then therefore treat them. And we do know that there's evidence of improved long-term outcomes if you use imaging in bifurcation PCI. I am actually going to stop. There is evidence to suggest that there is an improvement in long-term outcomes, including cardiovascular death and target lesion revascularization, but this tends to occur in the long term, so beyond 1 year, and it tends to be more exaggerated in left main PCI cases than others. So how does this translate to our contemporary current everyday practice? Well, we start off with imaging, and today I'm going to talk about IVUS, but this applies to both IVUS and OCT. So we start with our pre-PCI workflow. The first thing we do is we look at the morphology of the plaque. Is it high in calcium? Is it very fibrotic? Do we need to do special preparation? We then establish your dimensions. So you look at your length and you look at your diameters, both distally and proximally. Post-PCI, you assess the edges. You want to look for edge dissection. You want to look for geographic miss, so whether you've got significant disease on either edge of your stent. You also want to look for stent expansion and apposition. So we'll start off with a few cases where we can demonstrate this in action. So we start off with this. We start off with a 65-year-old gentleman who's got limiting angina and massive anterolateral ischemia on perfusion scanning. He's got this LAD diagonal bifurcation disease. There's some disease in the circumflex, but it's got negative FFR. So we're focusing mostly on the LAD and diagonal. So I started off with IVUS assessment of the diagonal. So you wire both and you start off with IVUSing the diagonal. And you can tell that your distal segment has got mostly soft plaque, so this is fairly easy to prepare. But more proximally within the diagonal, you've got fairly severe calcific concentric calcium. And therefore, you know up front, before you start your PCI procedure, that you need to be fairly aggressive with this lesion preparation. You need to start going through your calcium algorithm to crack this lesion before you're ready to stent. The next step is you want to identify your landing zones. So you look at your distal landing zone, the diagonal. We found an area without much plaque with probably a lumen diameter of about 2.5 millimeters, so you're going to take a 2.5 stent. We look at the LAD just proximal to the diagonal. We measured it about 3.5 millimeters. So you know that you want to be 2.5 distally, and the LAD is about 3.5, and then you measure your length. So we measured the length from the diagonal landing zone until the ostium of the diagonal, and it's about nearly 31 millimeters in length. Therefore, up front, you know that if it's 31 millimeters, if I'm going to do a DK crush, I'll take a 32 or a 33 millimeter stent. If I'm going to do a culotte, I'll take it to 38 so I can have more space for the proximal pot. You then do the exact same thing for the LAD. So the distal segment of the LAD lesion is soft plaque, but more proximally there is quite a bit of calcium, although the lumen is not too bad. You size your proximal and distal landing zones. So your distal landing zone is 275, your proximal landing zone is 3.5. And you look at your length and it's about 38 millimeters, given the fact that you need 8 millimeters proximal to the diagonal ostium so that you can do a proper pot when you do your PCI. And therefore, before you even start the procedure, you've got an idea of what your stenting strategy is. In this particular patient, I was going to go for a culotte because I wanted to guarantee the diagonal of the ostium is fairly ugly and we might struggle to recross it. So I know that I need a 2.5 stent in the diagonal, so I'll take a 2.5/38. I know that I need to pot in the LAD, proximal LAD with a 3.5, and I know that I'll take a 2.75/38 stent in the LAD. Now with that in mind, you want to make sure that the stent that you're going to use will reach the desired size, right? So every stent has got a different expansion limit. This piece of paper, I'm a bit of a nerd, I've got this on my wall in my cath lab, so I know exactly how big all of my stents will go. So for this particular procedure, I need a 2.5 and a 2.75 stent that will go up to 3.5 comfortably, and pretty much all of them do. But if you have a different size, if you've got an LAD that's 4 millimeters and a side branch that's 2.25, you need to maybe change your strategy from a culotte to something like a DK crush or a tap. So we start off with our procedure. We've got our data before we start. So we start off with our procedure, and we end up being very aggressive with this diagonal. It's quite a tough lesion. We start off with a semi-compliant, scoring, NC balloon, re-image. We've not fractured the calcium. We go back with a shockwave balloon and another NC balloon, and then we re-image. And here you can see quite clearly that we've formed multiple fractures within the lesion, and therefore the diagonal is now ready to be stented. We do the same with the LAD, only in this case all we need is a non-compliant balloon. So we balloon it with an NC, we go back and image, and we've confirmed that we fractured, so we don't need to go back with an IVL or cutting balloon or anything. We then proceed with standard culotte stenting. So all of us will do this fairly comfortably. So you stent the diagonal, then you go back and you stent the LAD, you post-dilate, you do kissing balloons, you do a pot, and then you reassess. So post-stenting, you're looking for edge dissections. We don't have an edge dissection. You're looking for geographical miss, so significant disease just proximal or just distal to the stent. You're then looking at your expansion. So you don't just look at it, oh, it looks okay. You measure it. So we measure our references proximally and distally, we measure our stent area proximally and distally, and we make sure that we're at least 80 to 90% expanded compared to our reference area. In this particular case, we're actually above 100% expansion. You can then further assess your bifurcation itself. So you can image the bifurcation, you can see how big the LAD is just at the point of the bifurcation. Here we've got an area of about 7.1, so it's pretty decent. You can also measure the ostium of the diagonal. You can make sure that you've opened it up very nicely and you've got a fairly good result. And therefore we're quite happy with this outcome, and then we do our final angiogram, and we've got a very good angiographic result. So now that we've presented these principles, you can use the exact same principles for every single case. So this is a different case, different anatomy. So here we've got a lesion in the mid-LAD, we've got a lesion in the ostium of the diagonal. The bifurcation where the diagonal is probably a 001, but there's also further disease in the LAD. Here we're planning to use a mini DK crush. We've sized up our vessels. We know exactly how big we need to go. Fairly simple after that. So we've got a very good expansion and apposition in both the LAD and the diagonal. And you can see here in the bottom right corner a very nice demonstration of what you should aim for in terms of your bifurcation imaging post-PCI. Now the other point that is quite useful when you're IVUSing or when you're imaging these lesions is it can help you decide whether you go with a 1 stent or a 2 stent process. So here you can see this patient has got significant proximal left main, significant proximal LAD. There's also disease in the proximal circumflex, and we're not sure whether we're going to do this as a 2 stent strategy and stent the circumflex up front, or whether we're going to take a more simple provisional strategy. As we know, if we can get away with provisional, it tends to have a better long-term outcome. So what we then do is we image. And there are certain predictors on imaging that will give you an idea of whether the side branch is likely to be compromised. So we look at the plaque burden, and we look at the lumen area of the side branch ostium, and we also look for evidence of problems in the main vessel just beyond the bifurcation, whether there's any remodeling or whether there's a very high plaque burden. In this particular case, the circumflex MLA is not too bad, so we proceeded with provisional stenting, and we ended up just doing a very simple PCI procedure. Let me just play this video again. A very simple PCI procedure. We didn't have to stent the circumflex. So imaging can also help you simplify what looks like fairly complex disease. So this patient has had previous bypass graft and all his grafts are down. So we've got this CTO of the diagonal, we've got a CTO of the LAD. There's some disease at the LAD diagonal bifurcation, but we're not sure if it's significant or not, or how are we going to go about treating the bifurcation. So we recanalized both the LAD and the diagonal. Once we've recanalized the diagonal, we did an IVUS pullback. So we've identified a decent landing zone in the diagonal, we've identified a decent landing zone in the proximal diagonal away from the ostium, and we measured it about 27 millimeters. So you know you can take a 225 28 millimeter stent, cover it comfortably, and you take it up to 275. Well, what about the ostium? The ostium itself is not so bad. So the ostium lumen area compared to the reference lumen area is 87%, so you've only got a 13% stenosis, and your plaque burden is quite low. So you're more comfortable here to just stent the diagonal individually, stent the LAD individually, and treat the LAD diagonal bifurcation provisionally, and that's exactly what we did. So we put one stent in the diagonal, we stayed away from the ostium, we put two stents in the LAD, we came back and did kissing balloons just to reshape the carina. And here you have an excellent result with TIMI3 flow down the LAD and diagonal, and we've not had to stent the bifurcation. So in summary, intravascular imaging gives you more accurate lesion assessment. You've got superior information prior to even starting your procedure. It helps you in your procedural planning. It helps you in getting optimal results, and it results in better long-term outcomes. The aim here really is consistency, right? We need to be consistent in every single case. So you want consistency, you want reproducibility, and you aim for an optimal result in every case. Thank you.
We can move to the next. Iyad Azzam, our friend from the United States. Iyad is a consultant interventional cardiologist from the United States. He'll be chatting with us about left main with ACS at the office.
Thanks. Great to be here again in in Amman, where I grew up, and thanks for the organizing committee as well. So I'll be presenting this case of impella-assisted PCI of unprotected left main. This is a 72-year-old gentleman with hypertension, dyslipidemia, and has been newly diagnosed with diabetes. He's obese. He presented to another hospital with acute non-STEMI. Echo demonstrated EF of 45% with hypokinesis of basal to mid-inferior wall. His EKG wasn't really remarkable. Diagnostic angiography at the other hospital demonstrated distal left main artery disease, horribly calcified arteries, proximal LAD, circumflex, and distal PLV. So his STS score was calculated. Risk for mortality was 1.6%. The cardiac surgeon at the other hospital did not want to proceed since his arteries are horribly calcified, which is equivalent to a porcelain aorta. So he was referred to our cardiac surgeon at the medical college. And while he was at the surgeon's office, he started having chest pain. So I was contacted, and we took him urgently to the cath lab for high-risk PCI. Again, we did right and left heart caths. EDP was 19. Cardiac output per FIC was 5.1, but he was having chest pain. And back to my proposed algorithm for mechanical support. This patient does have a score of more than 3, which supports the use of mechanical support, basically impella in this case. His EDP was more than 17. His presentation is acute coronary syndrome. We likely will be proceeding with unprotected left main artery intervention that includes atherectomy, and his syntax score is more than 22. So, right common femoral arterial access was obtained. We placed a 14 French long sheath, then advanced Impella CP across the aortic valve. Then using the single access technique, we introduced a 7 French 45 centimeter destination sheath and engaged the left main artery using a 7 French XP LAD 3.5 guide. Angio is as shown. There's distal left main, osteal LAD, proximal circ disease, and diag as well. This projection shows how horribly calcified, especially the LAD. So we wired the circumflex using a workhorse wire supported with a microcatheter, then exchanged the wire out for rotafloppy. We performed rotational atherectomy using a 1.5 millimeter burr, and it wasn't that easy really to make that dip in the proximal to mid-circ. Again, we optimized the distal left main osteal circ, then increased the RPM to 180,000 and advanced it across the proximal to mid-circumflex. After that, we wired the LAD and diag, performed balloon angioplasty of diag and distal or apical LAD to improve outflow without the intention to stent the distal LAD. So just 2.0 at low pressure. After that, we did multiple balloon inflations across the circ and LAD distal left main as well, using conventional and non-compliant balloons at high pressure, followed by IVUS. Then stented the mid to distal circ using a 275-38 synergy, and proximal to that we deployed a 30-16 millimeter synergy. Then left main into circ was stented using a 30-32 synergy and post-dilated the left main portion to 3.5 initially, then 4.0. This was IVUS guided. Then recrossed through the stent struts into the LAD. Performed simultaneous kissing balloon angioplasty, then stented the left main into LAD using 3.5-20 millimeter synergy. After that, we recrossed, so we used the culotte technique. After that, we did simultaneous balloon angioplasty using 2.35 millimeter non-compliant balloon at high pressure, then a 4.5 millimeter non-compliant in the left main artery at high pressure, and followed that with final simultaneous kissing balloon angioplasty. Final angio reveals good result in the left main LAD and circ, including the balloon segments in distal LAD and diag. Radiation time was 55 minutes. Contrast used 280 cc's. Impella was removed. The patient tolerated the procedure really well. Arteriotomy was closed using 6 French angioceal and 8 French angioceal and 6 French per close. Follow-up echo revealed EF of 65%. 1 year later, the patient is still doing great with no rehospitalization, no renal failure, arrhythmia, angina, or shortness of breath. And he says, I feel 20 years younger. Thank you.
Thank you, Iyad. This was really a nice case. Congrats. So if we don't have any more speakers, can we move to some questions? Is that okay? Or we have another speaker? Is Fadi around?
Fadi?
Assalamu alaikum. My name is Fadi Al Qaisi. I'm so sorry for being late, and I really appreciate the opportunity to present a couple of the cases, I guess. And thank you everybody for coming on Thursday morning. Again, this case, we did it a week ago in Abdelhadi Hospital, and it's titled Imaging Directed Distal Left Main Bifurcation Angioplasty. I have no disclosures. We have 67 years old lady presented with progressively worsening chest pain for a few weeks. She is known case of hypertension, hypercholesterolemia, diabetes, and insulin. Known case of coronary artery disease, multiple stents in the LAD and RCA before she established care with me. September 2022 was the last cath. She had patent RCA and LAD stents with severe diffuse disease in distal small LAD and small left circumflex artery that were treated medically. Proximal left circumflex artery severe stenosis that was treated with single drug-eluting stent 3.5 times 26 millimeter. She is known case of chronic kidney disease. This is a list of home medication that includes the typical dual antiplatelet therapy, anti-angival medications. Her blood pressure on presentation was 134 and heart rate 56. Her baseline, she has baseline anemia with the chronic kidney disease. Her new creatinine was 5.59, baseline was 3.9. CRP was negative and high sensitivity troponin was more than 1,000. This is his baseline ACG that shows sinus rhythm and ischemic STT wave changes. Echocardiogram showed EF 40 to 45% with severe hypokinesia of mid to distal anterolateral and inferolateral walls. Grade 3 diastolic dysfunction, mild to moderate MR with severe pulmonary hypertension. Previous echo in February as part of a follow-up in the clinic showed EF of 60-65% and no wall motion abnormalities. In September 2022, when she needed the left circumflex artery, she had preserved EF, but obviously wall motion abnormalities of the left circumflex territory. She was taken to the cath lab, but before I show you the cath lab of this presentation, let me get you a quick flashback for the stress for the cath she had in September. So this is her presentation in September that showed normal left main, patent stents in the LAD, severe proximal left circ stenosis that was treated with one stent. Obviously, you can appreciate the distal small vessel disease. This is her RCA that has also patent stents. We treated with one drug-eluting stent, 3.5. This is the position and testing while the balloon is up, showing patency into the LAD away from the ostium. This was the final result when she left in September 2022, a few months ago. Now let's move on to June 29. Obviously, you have noticed that this was during Eid holiday. So I was with my family in Turkey. So my partner, Dr. Ramzi, took her to the cath lab. This is her RCA. And this is her new distal left main, proximal left circ, proximal LAD. His impression was ostial LAD was the culprit lesion with the slower flow. So he did balloon angioplasty with 2.5 times 15 millimeter, relieving the ischemia, doing appropriate, better flow. He said the ischemic ECG changes improved, patient stabilized, and she was taken off the table. Right now, we came back and we had discussion with the family. What should we do next? And the discussion was, should we do a high-risk bypass or high-risk distal bifurcation left main? And the other decision that we did for her that she needed to have dialysis. It's already done, and we had a discussion with the family about the needs. After the discussion with the family and the patient, we decided for high-risk dual bifurcation lesions. So this is my procedure planning. The procedure planning was which technique to use. I elected to use DK crush. The reasons I used that because of the discrepancy between the sizes of the LAD and the left circumflex artery, and the primary stents will go to the LAD and will be crushed by the left circumflex stent. The other decision we made, it should be imaging directed because we are going to talk about different arteries. We have to optimize the sizing of the stents, and we have to use, it's a left main stent. And as you noticed, her RCA is not huge, so she is relying on this. Regarding the circulatory support, I don't believe we have much to think about it in Jordan. We have limited circulatory support. It's only intra-aortic balloon pump. If I had the choice, definitely I would love to use Impella in such a case, but we elected to use intra-aortic balloon pump on standby. This is the day of the procedure. We can appreciate the distal bifurcating left main. We wired both arteries. We started with IVUSing of both ballooning, obviously. Both wires were established. We pre-dilated, and then we established the IVUS. This is the LED IVUS. I will let the run. We started in the mid segment, and we are pulling back. You can appreciate the previous stents that they are not fully expanding. This is the previous stents. Then we are going to move to the ostial LED into the left main. This is the ostial, and this is the left main. And I will show you the still images. The big one is the ostial LED. The left upper corner is the left main, and the mid and the left lower corner, that's the under expanding stent in the LED. And you can know that each marker is 1 millimeter. Then we did a run for the left circumflex artery IVUS, showing that was a good expanded stent. Ostial is involved, and this is the ostial. I'm going back and forth just to show the ostium. There is some jumping of the circ when you are pulling back of the IVUS. And this is the left hand. It shows the ostial left circ. The right hand shows the left main. Conclusions when I did the IVUS was, number one, plaque modification is not needed for the ostial. I did not appreciate much of calcium in the ostium that need plaque modifications. Proximal LED is under expanded. It needs higher pressure for better stent expansions. The maximum diameter by measurement was 2.2. Having said that, visually it was more of a 3.0 artery, so we decided we settled down to 2.75 stent and post-dilated with 3.0. The left main diameter was 5.0, so we decided for a 4.0 stent in the left circ and post-dilated proximally in the left main into a 5.0. This is the LED stent placed covering the ostium protruding into the left main, and you can appreciate that's a 275 by 38 stent with the 3.5 15 millimeter parked in the left circ. The stent was deployed. We checked. We like the stent. Patency is good. We pulled the wire. We crushed it with the balloon. Recrossed. This is the recrossing into the LED. This is our first kissing between the balloon in the left circ and the stent in the LED. And then we delivered the stent of the left circ, pulling the wire from the LED. And this is a 4018 stent. And then this is the second kissing, obviously recrossing, and this is using the 3015 in the LED and 5015 into the circ. And post-dilatation, then we addressed the LED stenting. We went with the 325 very high pressures. We were able to post-dilate the distal of the stent. This is the mid portion, 3.25 times 12, very high pressure, going 26, 28. And then the good voices in my head said, stop, we're not going to go any higher. This is the final IVUS run from the LED into the left main, appreciating, although there is some under expansion in the mid LED, but the ostial LED stent looks good. The left main stent has good apposition into the left main. I will let it run. There is going back and forth just to show that ostial into the left main, no complications. This is the final images for the, and we were happy with the final results, and the patient was admitted to the ICU for observation. Thank you. Sorry for going over the time.
Yes. You can say here, thank you very much. Interesting, very nice presentation. There's certain teaching point in your presentation. First of all, in every patient with acute coronary syndrome, it's not preferable to be advance your IVUS catheter because you know that we're facing a tight lesion. So advancing your IVUS catheter might lead to the catastrophic or life-threatening cardiac arrhythmia. Very preferable to pre-dilate and you do it, pre-dilate the lesion with the balloon, and then you advance your IVUS. Excellent. This is a very teaching point. Pre-dilate, advance your balloon, your IVUS catheter, and then evaluate the lesion. So my question for you, are you studying the circumflex by your IVUS?
I did. I'm sorry, I did not include that. We IVUS both.
So what's the mechanism behind the stent failure in the circumflex?
There is no stent, that's why I showed the previous one. There's no stent failure of the left circ. The lesion was distal left main into the ostial of the left circ. The stent itself that was placed in September was patent without any restenosis. That's why I showed the both images showing that the involvement in the distal left main is a new de novo lesions, not involving any of the previous stents in the LED, neither the left circumflex artery.
So you think it's compatible with the definition of ISR within 5 millimeter away from the stent, less than 2 millimeter, right?
If you can, now you are referring to the LED stent that has a poor outflow. If I get the question right, would you please just repeat that?
So the definition of the ISR should be 5 millimeter away from the edge, and your stent nearly the ostium of the circumflex.
Correct. So if I understand the question correct, is why to use the 5 millimeter protruding into the left circ and not just to use the 5 millimeter just in the left main and use a 4O in the kissing between the left main, the LED and the left circ. Is that right? Is that the question?
Yes.
So usually some people, they may use just the 4O and just use the 5O for the proximal one. Usually I thought just to have that smooth transition and just have the bigger balloons and just to, not to go with the rule of 0.75 and then get the two balloons. I just like to have both stents to get their full size when we do the kissing. Obviously I don't go crazy with the pressures, just like the nominal pressure for the NC quantum, but I like when I do my final kissing to have the full expansion of the stent, of both stents at the same time.
We appreciate,
I know there's a controversial about that.
Yes, we appreciate some downstream in your LID stenting in this case. We appreciate there's some downstream in the LID stent.
Downstream?
Yes, downstream.
Yes.
This is because of what? Because of the eccentricity of the lesion, or there is any explanation, or there is need to go for a larger size balloon for post dilatation? Your eye was revealed there is some under expansion in the LID stent. Yes. We appreciate, and geographically there is downstream in the LID stent, right? So is there any indication to go further by the large size balloon to be dilate more and more?
Now, we tried the post-dilatation. That's all stent. There's multiple layers in that LED area. Not to mention that our stent was the last layer for the stenting. We tried to go for high pressure there, and it's a 2.75 stent. We tried to go for the 325 at 26, 28 millimeter atmosphere, and yet we were not able to break. Our decision was either to go even with high pressure balloons
or IVL,
which we don't have currently, or at that time we were running into, we know we had good results, we're just going to stop.
Thank you very much.
Fadi. I think we open questions from the audience, then we move to the panelists.
Thank you very much indeed, Fadi. But can you tell us
Microphone,
how did you manage her
Microphone,
renal
Marwan.
failure and anemia? Okay, interventionally it was perfect, but medically speaking, what happened to her renal failure and anemia?
Actually, she had chronic kidney disease. She was talked into dialysis multiple times. When I did her previous cath in September, her creatinine was also in late 2s, early 3s. And we were dancing around the dialysis at that time even. And we were like minimal contrast at that time. And God knows how she survived that procedure without ending up on dialysis. But when she presented with this presentation, her kidney disease progressed even larger, faster, and we all agreed, herself, family, that's the time. So we made all decisions together that we are going to go into, we dialyzed her before we put her on the table, just to make her more comfortable and lower the end diastolic pressure while we were working and causing her ischemia. So we don't want to have pulmonary edema while she's on the table, causing her ischemia and worsening of the LVADP. And she got dialyzed again after the procedure to try to remove as much contrast as we can after the dialysis. So the dialysis was talked about it a few months before, and this time just the decision and acceptance in her head matured enough to agree for it.
Thank you, Fadi.
Did I answer your question?
Please.
Thank you very much.
Thank you.
Dr.
I
Fadi.
just wanted to stress that intervention is not the only way of treating these diseases. This is the large epicardial vessels. But what happens to the whole system? How can we address medically? All right. This was the aim of my question, and thank you very much indeed.
Thanks,
Dr. Fadi, thank you very much for this nice illustration of using of imaging in coronary intervention. I have a question for you and a question for Iyad. Actually, there is no clear data to use or the clear guideline for using of the imaging in bifurcation rather than left main stem. We need more data about this to compare using the IVUS in every bifurcation or just left mainstem bifurcation? We need more data for that. To my knowledge, we have no clear or big study to compare using of IVUS and other imaging modalities in bifurcation other than left mainstem, to compare it with, so for example, for usual balloon or drug-eluted balloon. This is number one. The second for Iyad, actually we are the left circumflex in most of our procedure is a victim of the interventionist. Sometimes if you see CTO in the proximal, ostial, or distal circ with big RCA, we neglect that most of the, we try to optimize medical treatment. Interestingly, in these two cases, you put the mainstem stent to left circ, and in that previous session also left mainstem to the circ. Any something which is how you can, and you treat the LID as a side branch, which is big LID. I need on which base we can depend only on the size, area, size of the vessel, and other things. Thank you very much.
Great questions. The first question about the data to support clinical outcomes of using imaging. Actually, there are more and more data about showing improved clinical outcomes, especially with the stent restenosis, and recently, in the last couple of years, that they are actually increasing mortality benefits with using imaging. Now, personally, if there is a left main, it's an imaging directed testing. When I was in my last visit to Sky, I was shocked with the amount of the imaging. Every single case, there is IVUS before, IVUS before, after, OCT before, OCT after. Tomorrow, I'm going to present another case that I wish I had used imaging before I did the case, just because of the plaque modifications. Our
class of recommendation of using IVUS in bifurcation.
Now, again, this is my personal approach. Our understanding of the plaque has expanded and evolved rapidly. We rely always on the imaging of the cath itself, showing but this is a luminogram. It's a luminogram, which does not represent what's happening in the walls of the arteries with the degree of the calcium, fibers, plaque, all of that stuff. And that's why if I suspect there's a problem in the walls of the artery, I would use imaging to help me optimize the plaque before I do the stents. And this is a great example how we ended up with under expansion of the LED stent. If we had the chance to modify the plaque beforehand, we would have expanded the artery much nicer. And maybe one of the reasons that there is restenosis of the LED is the poor flow in that narrowed stent. So back to the question. Using images, I think that it's more and more important to be used, not to only stent optimization, but to understand the plaque and to use the modification of the plaque before we intervene. Obviously, in Jordan, we have a big challenge is, who's going to pay for that catheter? Who's going to pay for the IVUS? We don't have an OCT, it's the IVUS, and it's the old generation IVUS, the Volcano, which is the bulky one, whereas the Boston Scientific is the nice, sleek, small artery that can go through anything, and it has much user-friendly and much artery-friendly compared to the Volcano IVUS, which can damage something in its way. So in Jordan, we have some local challenges, mainly the catheter and the cost. Who's going to pay for that IVUS? Anyway, we managed to get good deal for this patient.
Thanks, Fadi.
Thank you.
Iyad?
Sorry, let me address his question, please. So the ultimate trial definitely showed improved outcome, and I totally agree with Fadi, who's a great friend of mine. The other thing, he touched also on this. When I treat fellows, it's not only, we need not only to interpret IVUS, but we need to know what to do with the information it's giving us. Treatment of calcified plaque, as you know, is different than, or optimizing it is different than when you have fibrotic or fibrocalcific or lipid core, right? The other thing is stenting technique. Sure. there isn't a perfect stenting technique. We all know this. Just do whichever you are more comfortable with, and the one that you can bail yourself out if there is a problem. Now, I always cringe when there is a crush technique. I don't like. I hate it with passion. It doesn't mean that I'm right. I just like culotte. So my second case actually was a culotte technique. So left main into circ, then recross, and I like to call it double kiss culotte technique. The problem, we see patients coming back with circumflex disease. I totally agree, and that's why, you know, when we crush a stent, and I know that, you know, Azzalini at the University of Washington is proposing also to crush the LAD stent, because these patients come back usually with circumflex disease, the ostium of the circ, not LAD, but we don't know yet. And when you have 3 layers of stents just across the ostium of the LAD, it's really, I just don't like it. I'm not sure whether, you know, my colleagues have more experience with mini crush, double crush, nano crush, whatever crush you want to call, you know, across the ostium of the LAD. I just don't like it. So which stent is primary, which one is secondary? Usually left main into circumflex, then left main into LAD if the size permits.
Yes, sorry, the microphone, Dr. Amin.
I have a question, please. For my comment is, what you feel about what your partner has done by inflating the balloon in the left main and then just call it a day. The other issue is, why would you dialyze the patient before the cath, knowing that hemodialysis might cause hypotension and you might close the left main and lose the patient? And my third question is, and that's for both the speakers, is what is your strategy when you follow up once you do left main stent or bifurcating stent? Do you stress them? Do you recath them? What kind of a strategy you guys follow? Thank you.
So I'll take the last question. So follow up clinically. There isn't really any more good recommendation. There is no recommendation really to do routine follow-up, and we do have a problem with this in the US if you just bring the patient to take a look. So we don't do that, and there is no screening stress test or follow-up stress test.
Okay. Oh, thank you very much. So, so excuse me. Sorry.
2 minutes.
2 minutes, sorry. Okay, thank you very much for all. Before we are end the sessions, I want to add some very practical point in the left main stem stenting and answering Dr. Adnan's question. Nobody like to stent the left main stem toward the circ. We try as much as to go toward the LID unless you are highly indicated for reasons, because the ostial circ, it's a weakest point, and the stent under expansion at the level of the ostial circ, it's a very powerful predictors of the in-stent restenosis. So try to optimize your result at the level of the ostial circ as much as you can. Why it's a weakest point? Because the torsion or cardiac motion will be at some mechanical stress on the angulation of the ostial circ and contribute to the in-stent restenosis. And thank you very much. Okay. Thank you very much. Okay, we finish the session and you can go to enjoy with the break. Thank you very much.